So we're going to carry on with a few more cases that will try and bring out some different issues, hopefully. So the next case is a patient in their late 60s who presented with a change in bowel habit and went to have a colonoscopy, and the colonoscopy showed a stenosing, malignant-looking mass in the sigmoid, but couldn't get any further. So what we would normally do for a case like that is biopsies would be taken and the patient would be sent for completion CT colonography to assess the remainder of the large bowel. And what we saw at CTC was a polypoid mass, and so this is the stenosed lumen, and this represents the mass. We find that what we tend to do when we're reporting our CT colons is that we'll do the initial 2D read, then we'll use the endoluminal view with the CAD, the computer-aided detection, on to find any other potentially significant lesions we may have overlooked. And then I routinely would save some of the endoluminal view images to add context to the NDT discussion, because most of the surgeons are scoping surgeons, and actually to give you a feel of what you see is part of the theatrical performance. It's all part of the show that we put on, but it enhances that discussion because it gives you an idea of what you're dealing with. This is a small lesion, large lesion. Particularly if we're talking about polyp cancers, it shows you the morphology. Is it over a fold? Is it stenosing? And so I think that the endoluminal views have quite a lot to offer. Anyway, I'll now show you this patient's CT with the other bits of it. And so what we have is this stenosing lesion. You can see why. And I would encourage you to make an assessment of the lumen, because the degree of stenosis is important, because actually if this is very stenotic and there's evidence of upstream, upstream obstruction, then that's going to change the urgency with which the patient potentially may be managed. They may need to go a bridge to surgery with a stent, and we use those on certain instances to allow potentially other forms of therapy. So I would encourage the radiologist to make an assessment of the degree of stenosis. But this shows this lesion, and we can see that it's infiltrating, and this was a case that I showed yesterday as part of it, and although I don't think it particularly shows well, this is the peritoneum that's coming down here. And so all of this stuff is in the extraperitoneal aspect. And that's important because it gives us a prognostication if we're seeing disease on the peritoneal side. All of this infiltration is into the mesentery, so this is a T3 lesion. And as far as I'm concerned, I can't see any disease which is spreading to the peritoneal surface. So I think this is a T3 tumour, not T4A. There's clearly multiple nodes which look far more than I would normally expect to see, and so multiplicity of nodes is something that will influence me reporting whether I think they're positive, rather than just simply size. Size trumps everything for CT, but if I see lots of nodes, and I wouldn't normally expect to, then my feeling is that they could be reactive, but I'm much more likely to say I think this is N1 or N2 disease. I think also in this patient, some of the extension is following the vascular plane, and so I'm going to state this as EMVI positive or EMVI2, because it's macroscopic, not microscopic. And now I'm going to have a look around to see if there's anything else that might make me think they're metastatic disease. Now you can see there's a nodule here. Now that nodule is on the wrong side. So if it's a node, it's a metastatic node. You have to call that N1 disease. If that's not along the draining vasculature, and if it's not a node, then it's disease within the omentum. And so this would be M1C disease, because if the liver's clear, and we would have included the chest as well to complete the staging, and if that was the only thing, this would be M1C disease. But as I would encourage everybody to do, as I'm sure you do, is to use all the information available to you. So by that, I mean use the orthogonal planes because it gives you different appreciation. So we're looking for that nodule, and actually you'll see that what it is where is that nodule? It's there. Okay. So actually you can see it's a urachal cyst. This is the urachus coming up here. There's the top of the bladder, and there's the urachus, and there's a small cyst within the urachus. So actually, it's not a peritoneal deposit at all, and actually, it's not M1C disease. But that's the power of use all the information available to you, because it's there available to everybody. Somebody else will come along and spot it and make you look silly. So to make sure that actually the orthogonal planes will often give you different relationships and identify things that you haven't appreciated, particularly adjacent organ infiltration. Those are things we want to be looking at. So this patient went and had their biopsies. And that was adenocarcinoma. So we're now left with what I think is T3 disease, N2, EMVI positive, M0.
Yeah, the initial radiology report, which may have come to me first, and that's why I put it on the MDT, might have said M1 disease in the omentum. And in a young 60-year-old, as in a fit 60-year-old patient, the alarm bells would be ringing quite strongly, because you'd certainly be thinking about, extending your resection to include the greater omentum. And occasionally, actually, in these patients, you might even be talking to them about having not only extended surgery, but a sort of peritoneal operation, which is only done in national centres and accompanied with intraperitoneal chemotherapy. So it's absolutely vital. I'm not so worried about all that stuff in the mesentery, because I know if I do a high tie on the inferior mesenteric artery and take the vein IMV at the lower border of the pancreas, I'm likely to get all of that disease out and still have adequate blood supply to my non-resected ends of bowel to achieve a safe anastomosis. So this discussion, Bruce has now had a good look at it with orthogonal views, and he's characterised that as a benign lesion, so now I can go ahead and do what we call a high anterior sectional left hemicolectomy on this patient.
Okay, so that's what we received. So initial biopsies were diagnostic, and this case then raises a few issues about pathology staging and interpretation of TNM8 in particular. So the first of these is the T stage. So this was obviously cut up as a nasty advanced tumour, these mesenteric tumour foci read macroscopically, so we'll come on to those in a second. But the primary tumour, so this is a section from it, and here is this is the serosal surface, so this is this anterior aspect where this line is the dividing line between PT3 and PT4A disease under TNM8. So you can see the serosal lining is definitely tickled, it's inflamed and fibrous, and this distinction can be very, very tricky for a pathologist because it's not a minimum 1 millimetre distance or anything like that. We have to see tumour cells breaching the serosal surface to confidently say that the tumour has entered the peritoneal cavity and therefore implying risk of peritoneal recurrence. So in this setting, what we will be doing will be examining multiple levels. We can do some stains to look for the elastic lining of the peritoneal cavity, but it's a bit of a grey area as to what is enough to make it PT4 disease. Personally, in this view, I certainly wouldn't call this PT4 disease. There's clearly a line of encapsulating connective tissue here, but this is the distinction we're trying to make. In this context, it's probably trumped by the other adverse features elsewhere, so it's not a major management issue, but in isolation, if there was no negative disease, this could be an adverse feature that might push the patient towards adjuvant chemotherapy and clearly a worse prognosis. So I want to spend a bit of time having a look at this representative sample from this patient's mesentery. So we see here a lot of foci of tumour, clearly not connected to the primary tumour, and what we have to try and do is identify and classify these and see what pathways are involved. So I don't want to dwell on this, especially the pathologists in the audience that spent quite a bit of time discussing this yesterday. But this is what we're faced with now in terms of TNM8 and trying to interpret these foci and grapple with this new entity of tumour deposit. So essentially now, when we're faced with discontinuous tumour, we have to try and classify it as being an involved lymph node, extramural venous invasion, perhaps rarely extramural perineural invasion, and then really as a diagnosis of exclusion, a so-called tumour deposit. So we have to try and classify it into one of these areas, and if we're not convinced where it's come from, then it's a tumour deposit. What we're going to do is...
So just to be clear for my idiot surgeon's brain, so if you don't see lymphatic, if you see this nodular tumour and you can't see blood vessel or lymphatic channel, that's just then called a tumour deposit, as in, what's the classification, N or N?
N1C, N-IC, if there are no birth nodes, and we'll explain this. So basically, if we have a look at these areas, and again, this might be interesting just to get the radiology viewpoint in this. So there's a lot of subtlety and a bit of subjectivity still around interpretation of these. And it's something that since TNM8 has come out over a year ago, I've evolved my practice and interpretation of these. And I think in some cases it's very straightforward. For example, if we look at this focus, clearly that's a big thick walled vein with red blood cells in it. If we want, we can do immunohistochemistry for a muscle marker to show the venous wall, and clearly that can't be anything other than extramural venous invasion. But with tumour here not staining positively, so it's glandular material. That's clear-cut venous invasion. Like this is more subtle, smaller vessel venous invasion, rounded. Pink stuff is still muscle and it's beside an artery or arteriole, so that's always a clue. And we can do, as an alternative to Desmond, an elastin stain and look for elastic tissue in the vein wall. So this is clearly venous invasion as well. But it's when we get onto this sort of focus that things become tricky, because now we have tumour here beside an artery, but it's really quite ill-defined, possibly vaguely rounded, but no convincing vein wall, and I think on H&E or any stain, so I think this is a tumour deposit. Okay, but definitely some people would still interpret this as, oh, this is probably a business from venous invasion. And when you think or you're convinced that this has arisen from venous invasion, then it's classified as V1 disease, not tumour deposit, therefore impacting potentially the end stage. So if the oncologist in particular is fixated on the end stage, adjuvant chemotherapy only if it's anything other than N0, then that can be a problem. But hopefully the other adverse features are interpreted similarly. Here's another example of one or more tumour deposits. Definitely these are very ill-defined, not beside any evident vascular structures. One of the issues here is we're meant to count tumour deposits, but we don't have any criteria for minimum size or minimum separation between tumour deposits. So I'm fairly sure these are tumour deposits, but I have no idea if it's 1, 2, 3, or 5, because there aren't criteria. So we just have to do the best we can. So in isolation, this would add up to stage EN1C disease. But the interesting TNM ruling is that, sorry, before I get to that, one more focus. And this slide interestingly shows more venular invasion here. In this area in more detail, you can see tumour cells floating in this lymphatic channel. So no red blood cells in here, just lymph and white cells. And the D240 you stay in that channel if you're interested in it. So this is extramural lymphatic invasion, which unsurprisingly is associated with
Could you
lymph
just
node
go back to
deposits.
the slide?
Yeah.
So where the radiology comes in is that, and we know this from the Mercury study, is that simplistically in my mind, there are two things that tell the pathologist that this is within a vessel and not a tumour deposit, which is a lump of tumour, not in either in a destroyed node or in a vessel and you can't see. Is that, you know, I can see that's a long tubular thing, so it's in a tube, so that's fine. I don't have a problem with that. But the problem is that this is what the pathologist is looking at, which is a cross-section. So if you don't identify the vessel wall, you're making a guess that it's a tumour deposit, and we know that tumour deposits, as they stand N1C, carries a worse prognosis than just M1 disease. But what the radiology does, and it's particularly pertinent for rectal cancer cases where the detail is so much better, is you can scroll up and down, and we will see a deposit, but actually we can see the flow void, or the vessel emanating above and below, which might not be in the section that the pathologist has to them. So that's why you should be working together. And ideally, you could say, well, I think it was at the 3 o'clock position in the specimen, the mid-rectum. We can go back and look at the rectal MR and say, well, actually, I can see that what you're talking about, and it relates to a vessel. So I think this is what we would call discontinuous vascular invasion. So this is a tumour deposit that isn't in continuity, but I can still see that it originates within a vessel. And that changes potentially the prognostication for that patient. Because EMVI2 is bad, but N1C is worse. So that's how the pathology and the radiology potentially should be working in parallel. We work together to fill in the gaps.
I think that's probably even better illustrated at this lower power of this slide, because Bruce says so the benefit of radiology is that ability to use the third dimension, as it were, and make these things potentially join up, or if we follow this through in levels, maybe then the venous wall then becomes obvious, so we know then that that tumour deposit has arisen within extramural venous invasion. So here we've got venous invasion clearly, and we've also demonstrated it on a masking scaling down here and here. So this is a lymph node, which will come to in a second, but the chances are that these foci of tumour deposits in isolation probably have arisen within venous invasion. But what TNM8 is now doing, I think, quite sensibly, is we're not really guessing anymore. So if they have that evidence, that's fine. We're aware that the tumour deposits have to have got there some way, and venous invasion is by far the most likely. But there could be other pathways involved. We could be completely destroying nodes. Remember, we've moved from TNM5, where if any of these things measured 3 millimetres or more, it was called an involved node. Why not? Why could you not have the MDI that's over 3 millimetres? So we're definitely in a better position now. And what TNM8 is trying to do is identify the metastatic pathways that are engaged by tumour. And it's been shown that if you have more than one of those engaged, so if you could kind of through house of lymph nodes involve EMBI and tumour deposits, which are probably bad EMBI or some other pathway engaged at perineural, then that's by far the worst prognosis, strong predictor of peritoneal disease. And so these things are additive, which is why there is a limitation to TNM8 in that once you have overt nodal involvement, like this nodule, I was very impressed with our agreement yesterday, and the pathology group deciding that, yeah, this is a capsule, these are subcapsular lymphoid aggregates here and here. This is clearly a lymph node, is almost completely replaced. So this is all tumour, but there's enough evidence here that this is a lymph node. So this is all in one section. We've got extramural venous invasion, extramural lymphatic invasion, a lymph node involvement, and tumour deposits. So that's one slide from this case. So because of this single node involved, then N1C under the tumour deposit classification is ignored under TNM8, and this goes back to N1A. So that's the bizarre thing, that even though the adverse prognostic features of tumour deposits are well established, under TNM8 we're only meant to record them in the absence of overt nodal disease. I think what most of us are doing are recording this separately. So strictly speaking, this is N1A disease under TNM8. Well, this is assuming there weren't any other nodes involved, but the tumour deposits are recorded under indicative of an adverse prognosis.
So what these guys are also doing is they're predicting for me the type of potential recurrence this patient is likely to get in the future. So if he'd said, this is a young patient who's fit, who's got clear serosal involvement, you'll be thinking more of peritoneal disease as an early potential for recurrent disease. And in one particular case that Bruce might not remember, I had a patient with a discontinuous nodule on the peritoneum, and we gave him adjuvant chemotherapy, and we actually then re-laparoscoped him, I think it was 12 months later, or even 6 months later. And the benefit of doing a laparoscopic operation in the first instance is you can go back laparoscopically. In this case, no adhesions at all. Took some mental biopsies and biopsied a few peritoneal areas, and it turned out that he was negative. He also had this kind of nasty mesenteric disease, and it turned out that he then got para-aortic lymph nodes which were involved, and he went to Basingstoke and had a radical operation with intraperitoneal chemo. Unfortunately, he's now got further metastatic disease, but it will dictate what kind of follow-up you have, how you can predict the kind of recurrence they're going to likely to suffer from. Very important conversation.
I think those conversations add a lot more than just the bottom line TNM8 classifications, which really doesn't do justice to the progressive features evidence. So strictly speaking, so the red changes are the new TNM8 issues of severe substratification of end-stage inhibition of the N1C category. So in this case, we've got an engagement of venous invasion, phantom-based lymphocytes, and tumor deposits. And strictly speaking, this is PT3's M1A, V1 disease with tumor deposits.
So, just to add from the radiology point of view, the CT of colon cancer is not just the report. There's not no metastases seen. It is to make the TNM, EMVI assessment as well, because that will change the discussion about that patient's management before we get the confirmatory pathology. You know, that patient may not go to surgery. And when the Foxtrot trial is published, which is looking at chemotherapy up front, influencing downstaging and outcome, it may well show that those kinds of patients will have had preoperative chemotherapy. So we need to be used to doing that now. That's on a staging CT, and we're looking at it. We should do what we do for rectal cancers, and then actually you'll start to see stratification and treatment strategies for patients with colon cancer the same way we do with rectal cancer, and then the outcomes will start to improve. So we need to be doing, as radiologists, we need to be doing that now. So the next case is a patient who presented with some rectal bleeding and had a colonoscopy, and the colonoscopy demonstrated what looked like a very large lesion. Endoscopically, it looked rather like a cancer. So we went on and did the staging MRI. This is the lesion. Let me show you. Sorry, this is the lesion here, which is this thing. Okay, so you can see there's some mucin being produced into the lumen, and there's a nasty looking lesion there, which if you look at the other planes, it's broad-based, polypoid thing, and we're not really seeing the margin of the muscularis propria as well as we would like, and then we've got that thing sticking out the side. Now, when you see anything sticking out the side of the wall, the assumption is that that is a tumour, a vessel, or a response to tumour. So your tumoral fibrosis. But as I asked the question yesterday at Morris's, do we see peritumoral fibrosis in polyp cancers? And the answer is no, you don't. So now I've got something that sticks out the side here, and I now know, I didn't before, but I now know I can't call that peritumoral fibrosis if it's a polyp cancer. So suddenly, if that is what it is, either invasion of tumour into a vessel or peritumoral fibrosis, this can't be a benign lesion, because you wouldn't get either of those features in a benign lesion. So now we've got morphologically something that endoscopically looked like a cancer. We've got an MRI that shows something sticking out through the wall, which I think looks like a cancer because it's either peritumoral fibrosis or it's EMVI. So we're thinking, well, radiologically and endoscopically, we think this is a cancer. Now, the only other possibility is that big polyps need blood, so they get vascular improvement. And that is one of the areas that we fall down, is that you'll see in these big polyps where there's retraction of the base, is you see vessels coming in. Now they may just simply be normal vessels feeding blood to this thing that needs blood. And that's where we'll get it wrong. If you can see a flow void in it, then then clearly it's a vessel, but you might not see that. All right? So in this case, morphologically, it looks like it, and had a biopsy, which showed
tubular adenoma in the previously.
Surgeon is going, oh God. So my radiologist is saying this is cancer, and he says it's benign, low-grade dysplasia. So next thing is, who's seen this patient? Hands up. No hands are going up. So I mean, obviously, everyone's going to say, see the patient, get more biopsies, because there's some nasty features on here. So there's going to have to be a discussion about preoperative treatment, assuming the patient's fit and wants it, by way of chemoradiotherapy. We haven't quite examined all of the margins in the nose yet, but that's the way this conversation's going. And actually, we're much more focused on these vascular things preoperatively than we used to be, and we're aware that they're almost as important, sometimes more important than even nodal involvement, and they can extend very close to the margin, particularly posterior. We've got superior rectal, so we're sort of thinking about this. So we're going to have to see this patient, have a look inside, and get more tissue.
Can I ask, Mark, would you, in that context, if you're trying to get more tissue, because obviously pathology is always on more and bigger and whatever, so
yeah,
would you be concerned about taking lumps
Well,
of this?
so that's a really good question, and of course there remains a slight possibility, I suppose, that it's still a benign lesion. And so I'd want a competent, certainly you see them in outpatients, and if you can't feel it with your finger, because I think from the sagittal that looks new to upper rectal, so you may not be able to digitate it, but you might see it with a rigid scope. But then again, the prep's soft and poor. It's a really poor way of looking at patients, but it can give you some basic information. Then you'd want a really competent endoscopist who not only could take the biopsies of adequate sampling size and number, but also assess the morphology of that lesion. So you're thinking an endoscopist who can do magnification and chrome endoscopy with dyes to get pit patterns and magnified views of histology. I mean, we're sort of gastroenterologists now becoming histopathologists live. So there's a few things that we're playing on our minds here with.
So the other things that the radiology what we have to offer is to make sure we've made a full nodal assessment. There aren't any nodes.
Okay.
Potentially this patient has got a big polypoid lesion. Where is it? Well, it's middle of the rectum, and obviously we measure from the external anal verge, measure up to where its margin is. So here's the peritoneal reflection. All right. And potentially, I think it's fixed posteriorly. So we might get into the discussion about a transanal microscopic resection, so TEMS procedure, because it's at the back. So if you make a hole all the way through the full thickness, then actually you're into the mesorectum without worrying about peritoneal compromise. So that's another thing that the radiologist needs to accurately describe. But we would still be left with not knowing whether that thing that we could see on the is whether that was a vessel or whether that was a vessel, or whether actually it was some kind of tumour infiltration.
So now with my TEMS hat on, I'm sort of thinking, well, Bruce, you know, sometimes you don't really see and tell me the extent of the base of this lesion. You've already said anteriorly there's some peritoneal reflection coming down. I know that I sometimes look in on these and I suddenly find myself into the peritoneal cavity. And if this is a malignant lesion, that is a disaster for the patient. If there's not much mesorectum behind it, again, if you do a TEMS or transanal approach, you can compromise the mesorectal chain if you need to come back and do a radical excision at TME later on, because you create so much fibrosis and reaction that your margin will be destroyed. So this is a very nuanced, difficult decision to make at the time of endoscopy, We want somebody that is experienced at taking out these lesions if they can be done endoscopically or surgically, that can make a decision or take the adequate biopsies to give us a further discussion in the MDT the following week, hopefully, with greater information.
So if you're in a centre that does lots of endoscopic ultrasound of rectal polyps, then I think this would be something that would have a lot to offer. Because actually, if the EUS can see the submucosal plane, then this patient can have organ-sparing approach. Because we've not seen on radiology anything else necessarily, because they would also be able to potentially identify the base. Because actually, if there's no tumour into the submucosa, then that has to be a vessel, a normal vessel. So that additional information would help. So with this particular case, we went around the houses, we said, it looks bad on endoscopy, radiologists don't know what that means, and although there are no other adverse features, potentially this is a T2 or an early T3 cancer, T3A cancer, and so that would be a candidate for straight to surgery. And this case went straight to surgery, had TME, and it was a low-grade tuberculous adenoma. Right. So that is a normal vessel. Right. So it shows you that it can be difficult to be definitive, but these are the kind of discussions that we'll have. Now, endoscopically, I think it was assessed, and it was just felt to be too extensive to do an endoscopic approach. So that had sort of made the decision for us that there wasn't a local resection possibility, so then you had to go to definitive surgery, even though there was a risk, because we'd only had the biopsy had shown low-grade dysplasia. So actually, it was always possible that it was a low-grade dysplastic polyp and not a cancer, but actually it still had to be managed surgically because you couldn't get it out in another way. Even a piecemeal resection was going to always leave you worrying that you might have left the focus of cancer behind.
But having had that discussion, now I'm comfortable to offer the patient the TME, and it's also worth saying now, it's a really complex area, this surgically, because the patient may have done a little bit of research and they've heard about open surgery, laparoscopic, multi-port surgery, single-port laparoscopic surgery, robotic surgery or robot-facilitated surgery, transanal total mesorectal excision, sometimes facilitated by a robot at both ends. So depending on your patient, you may be having a very lengthy discussion about not just doing a TME, but how you approach a TME. And I think I've got one of those, the slide you showed of couplet dukes, which I think is very neat, which says it really, it's important your surgeon is comfortable with the technique they're doing. So if I was a patient and I had a surgeon who only does open surgery that does it very well, like Bill Heal, for example, I would say do it open. I wouldn't say, well, I want it laparoscopically, or if I wanted it, I would go and find a surgeon that was comfortable and skilled in doing that technique.
So I think we've exhausted that case. Next one is a patient, rectal bleeding, and went to clinic, rectal examination, the palpable tumour. Biopsies were taken through rigid sigmoidoscope at the time. Patient then was referred, had a colonoscopy. The rest of the large bowel was clear, and it was just a low lesion that looked like a cancer. And the patient was in their 70s, I think was it, and so was then referred for an MRI.
So the biopsies showed abdominal carcinoma.
Yeah. And so so not having your imaging available immediately leads to frustration at meetings and makes you look like an idiot. So that's all part of the get it right first time thing, and do your preparation. Hopefully I haven't. Well, this partly because it's this thing. So showing you the coronal images on this patient, and what we can see is a thing that looks like cancer. I can see the muscularis propria very clearly, but it is a low tumour. It's extending down below the levators, and on the sagittals I can see that it's down to the margin of the anorectal junction, so this is going to, it's into the territory of a low approach, and we know from multiple studies that our sensitivity and ability to detect invasion diminishes as you get nearer to the sphincters. We're less accurate. So you need to be mindful that we might be getting it wrong. But this does, to me, look like the intersphincteric plane, or the distance to the levators. It looks like it's intact. So I would stage this as T2, N0, EMVI0, MX on the basis of this. But you need to look at all the rest of it, particularly looking at the pelvic sidewalls. Very low tumours, make sure you look at the large field of view T1, look at the inguinal regions, because just occasionally it will go around that way, and that's acceptable nodal drainage for a very low tumour, in the same way that you see with an anal cancer. And these will behave a bit like anal cancers in their behaviour. But you need to look at all of the images clearly, and for anything else that would affect what you do. And if we look at the axial images, this patient, they've got a prostate carcinoma. Now, just a word of caution here. For those of you who do your prostate imaging as well, you'll be aware of the multi-parametric assessment, but actually what you need to remember with so if you're looking at the DWI images to make you feel more comfortable that patient's got a prostate cancer, look very carefully at how it's done. Because how we do our DWI diffusion imaging for rectal cancers, our highest B value is 800. That's not high enough for prostate. So you will potentially miss your prostate cancer on the DWI imaging because the parameters aren't correct. So on T2, I'm comfortable that that is a prostate cancer. The ADC map will help you, and the ADC map shows that this is a tumour, but we can't see it showing as a bright focus on the DWI because of it's a technical factor. Is we haven't got the B values is not high enough. So it's just a little tip of how you do your rectal cancers. Rectal cancers aren't. They don't give you everything you need for multi-parametric assessment of the prostate cancers, and they may need to come back for additional administration of contrast and the B values which are high enough. So we're left with a patient who has got, on imaging T2, N0, EMVI0, MX, and the rest of the things, there were no metastases, but they've got prostate cancer as well. Happened last week.
Surgery?
Biopsy?
Cancer, provenable carcinoma?
Right, so I mean this is now, I'm just thinking, well, this is a logistic, clinical, bloody nightmare in a male patient who's probably going to be fairly old, and he's had that prostate cancer, and you're sending it to the urology MDT. And they may or may not, as Bruce has said, want further imaging, a differently weighted MRI, plus obviously a PSA. And I'm sort of hoping that they're not going to say we need a transrectal biopsy. I mean, that might be in and of itself a risky thing with an associated low rectal lesion. Actually, it's probably not going to be possible to get a transrectal biopsy because of the adenocarcinoma sat down low, least of all with the patient of weight. So let's say, for argument's sake, they just say we can watch and wait this thing. Okay, we'll just rescan him after an interval. Now we turn our eyes towards surgery, assuming the patient's fit. and all of our patients for major rectal resection now undergo what's called cardiopulmonary exercise testing, so that they're measuring their ability to take in oxygen, excrete carbon dioxide on an exercise bike, and that gives us a very accurate idea, based on the age, the comorbidity, and the cardiopulmonary exercise test, of that patient's likelihood of death and complications from having major rectal surgery, down to individual percentage points. It's so accurate. And it's not just based on papers and international series, it's based on the experience in my hospital of operating on these patients and the legacy of data that's been accrued. Surgery-wise, we're not looking at a restorative resection here. So this guy's got carcinoma slap bang in his anal canal, and I don't think any surgeon in the world would offer this patient a restorative resection. If it's 3 or 4 centimetres, a bit of space between the anorectal junction and the tumour, yes, there's a chance of a restorative resection, and you'll be thinking about an ultra-low TME or a TA TME, transanal TME, these kinds of things, with all the other things. But basically, I think this patient needs an abdominal perineal. Now, I'm thinking about the size of my resection field. He's telling me this is T2N0. We can see the muscularis propria. The likelihood is we can preserve a significant amount of pelvic floor to close at the end of the operation, instead of doing a big cylindrical resection where we take the levators out of the pelvic sidewall and have to reconstruct either with native tissue, so we're talking about a rectus abdominis flap based on the inferior epigastric artery, or we're talking about something like a biologic mesh, which we use quite a lot in these situations. On the other hand, we might be able to just close the pelvic floor, which is the best and most effective and safest way of doing it. And the other thing, of course, again, if it's a younger patient, we're sort of thinking if there's anything adverse on the histology, those factors might drive us towards having short course radiotherapy and then operating just a couple of days later after 5 graves of radiotherapy for 5 days, and then you operate Monday, you go radiotherapy Monday to Friday, and then operate hopefully Monday or Tuesday the following week.
So the confounding factor for this patient, we would have had all of that discussion because they've got prostate cancer. And the reason why that confounds the problem is that the treatment options for that patient for prostate, as I'm sure you will know, is hormone treatment, brachytherapy, chemoradiotherapy, or surgery. So if we start to introduce radiotherapy to the rectum, that compromises the curative intent treatment radiation-wise for the prostate. And although even I would simplistically say, well, can't you do both? And the conventional radiotherapy that's given will not do both. Now, they can do some novel treatments and modify the dose modulation to potentially do both, but that's not what the radiation oncologists like to do. And so that will affect the discussion. And then you're talking about the fact that they may have a higher dose of radiation to the prostate that will impair healing after the surgery, or potentially impair the surgery, the ability to do the surgery, because you're then upsetting tissue planes low down in the pelvis. Yeah. And so these are all things in discussion that will come out. And from a radiology point of view, we need to make sure we describe accurately where it is and all the other adverse features that will influence which treatment line we go down.
So, post-op specimen, I don't have images of an APR or PT2 untreated tumour. This is a slightly higher rectal tumour, just to fill the gap. I'll show some images of an APR resection and a TME in the final case, but here we basically have, so we know this is higher up because we've got quite a good bulk of mesorectum around it. But this is a tumour, and macroscopically this looks like T2 because the muscularis propria is here and the tumour goes into it, but there isn't really any evidence on macroscopic assessment of tumour extending beyond that. And that's backed up by the histology, which shows tumour into but not beyond muscularis propria. So this is the line dividing T2 and T3 disease, and that hasn't been reached. The nodes are all clear, margins obviously clear in this context. So PT2 M0, M0 is the final function state.
Clinical follow-up only, then we would say. no need for any adjuvant chemotherapy in this patient.
So, in this case, so now we have a patient who is rectal bleeding, local examination, looks like they've got a rectal cancer, and the biopsy shows adenocarcinoma. So we've gone and done the staging. CT was fine, but the MRI has been performed, and these are representative images. And in this case, we've got nothing. Oh, okay, so we've got a bulky tumour, which anteriorly I can't see confidently the margin. Now, some of that is because it's a bulky tumour; it fills the space. And if you, so you have to look very carefully at the muscularis propria, because the lower down you get, it may still be T2, but if there's no space, you've got to be certain that you've got a T2 tumour. This, I don't feel confident. This is the back of Dennevilliers fascia, and I think that is out at the front. In addition to which, it's low, so it's also, we know it's going to be difficult. These nodes, if we measure them, are big, they're round, they're heterogeneous. Interestingly, if you look at that one, this is where potentially there is a vessel. You can see how that is actually, there is a vessel there, follow that down, and that lies in the line of that vessel. So this is one that actually, that might not be a lymph node, and I would want to spend more time scrutinising that, because that could be discontinuous vascular spread. That suddenly puts this into a worse category of some more aggressive tumour, worse prognosis. So already we're starting to see things, A, the margin is threatened or in fact involved, potentially T4 disease anteriorly. I've got nodal disease. I've now got evidence to suggest a discontinuous vascular spread. That's the bad end of EMVI2. So all of these features are bad. And so we would then discuss this patient at the NDT. So my final stage of this will be T4B, into the prostate, N2A, there were 4 to 6 nodes, EMVI2, and then because we don't have a code for discontinuous vascular spread, I would have that as, I think there's discontinuous vascular spread, that's part of EMVI2. Pelvic cycles are fine, no evidence of metastases from the completion staging, M0.
Being a surgeon, I just walked out of the room, and they're therefore tearing their hair out because he presented with histology while I wasn't there. So
with biopsy confirms that in person.
Okay.
Usually pathology.
Okay. So yeah, and again, and distant metastases, no sort of organs.
So prostate.
Yeah, and I think this is where the oncologist would be hopefully paying attention, not walking out the room, and be thinking about some preoperative long course chemoradiotherapy for this patient. And also I'm hoping my Polish colleague Sebastian Smolerek's in the room. He works in my hospital, and he would be thinking about extended organ resection in the pelvis. And he has a very good relationship with a urologist who does the same kind of thing for cystectomies, often involving us for prostates and bladders. And they'd be getting together in a younger, fitter patient in this situation and thinking about a pelvic clearance based on the results of the long course chemoradiotherapy, the restaging, and a further discussion in the MDM.
So we didn't cover that in the radiology session yesterday because it was beyond the time I had. But that's something else that, from a radiology point of view, you need to be aware of. What are the possible exenerative planes? Are we talking about coccygeal, sacral, at what level the sacrum, periosteum, anterior compartments, lateral involvement? What, can you get to the pelvic sidewalls from an extended TME? These are all things that we, as radiologists, it's not just TNM. those are all the other things that make the difference to optimal management of the patient. And having insight into the possible surgical management strategies means that we look for the information that will guide that treatment decision. We don't make the decision, but we present the information to allow somebody who does that surgery to decide that that's the candidate for it or they're not. Right? So,
and additionally, to put these things before the patient, because often you find with these kinds of things, the patients say, well, I'm not having 2 stomers, I'm 78 years of age, I'm not going to have an ileal conduit and a colostomy. So you have to then take these findings back to your patient and say, this is what we found, these are the options for you, and allow them to come to an educated and informed decision as to how to go ahead. And that's very strongly now covered in law in our country, that consent is not just about doing what most doctors would see as being reasonable. That won't get you off it. If the patient sues you and is found to be, and you're found to be guilty, you've got to actually do what is a reasonable body of evidence suggests you should do, and also cover things like unusual complications that they might suffer from that we weren't covered under law to have to tell patients about before. So there's awful lot of issues that we have to go through now that we didn't have to go through a few years ago, including extended surgery.
one of the things that we're finding, we don't do it very often, but we're doing it more frequently, is that occasionally I go to clinic and I sit down and demonstrate the radiology with the surgeon to the patient to enhance that discussion process. I don't know if any of you went to RSNA this year, and there's an awful lot about artificial intelligence, and the North Americans are feeling very worried that they're all going to be out of a job and they won't be able to afford their Ferrari. So they see themselves going down the line of being the patient's advocate, the demonstrator of pathology. You know, this is a big part of what we do, and actually increasingly you'll find that that interaction may well be the way, a direction of travel, is that you will be at the bedside demonstrating in the same way you do in an NDT the pathology to the patient, allowing the surgeon to have that discussion. You might find that's quite a frightening thought, and why you went into radiology in the first place was to avoid patients, but actually that is potentially a direction of travel. And I must say, when I've done it, it's been incredibly fulfilling, having that, being part of that team and helping that decision-making process.
If you have a good report,
Sometimes it's either been patients asked, usually in the context of a challenging patient, where actually the treatment decision that we've made without them isn't necessarily something that the patient's going to like to hear. So, the implications, and so to have that additional evidence in front of the patient to allow them to weigh up the factors with the surgeon, not just surgeon, you know, I know best, this is what you get. It's, well, these are the things, this is why we've come to the decision, and here I can show you this tumour, and I can show you the picture of the prostate, and why we can't have an operation at this time. And that kind of decision is invaluable for that discussion, and it maintains the trust that the patient has in the treatment decisions that are being made. So this patient gets radiotherapy, chemoradiotherapy, and we repeat the MRI. This is done at 8 weeks, and what it shows is we're seeing some changes of radiotherapy. You can see that the submucosa is starting to look a bit edematous, higher signal as the effects of radiation. You can see that actually there are some changes in the fat anteriorly. But if we come down into the tumour itself is smaller, so we're seeing a TRG probably 2 or maybe 3, so it's a volume, and I assess that, what kind of response we've got. But actually, that anterior margin, it's still involved. So it looks good. What about the nodes? Well, they now have gone. Maybe that was retracted, it's still just about there, maybe that discontinuous. And actually that one, you can see much more clearly now, I think, if we follow that black dot, is that thing we thought might be a node actually very much is in the line of that vessel. That is discontinuous vascular spread. All right, this entity that is, so we don't just make it up, it does actually exist. All right? So this is looking good. But he's still got an involved margin.
You might say that, but he's not the surgeon. He's just saying good response. I'm thinking I'm going to have to operate based on the original imaging, especially in a younger, fitter patient to whom that negative margin is absolutely critical. So the problem is, the immediate problems are things like of extended surgery, and we're talking about taking away the seminal vesicles, for example. Even the prostatic capsule, if it's low down, is blood loss. And that may inform the kind of way that you do your surgery. You might think, therefore, open surgery is more likely, but actually the way that energy devices work nowadays, laparoscopically, without robots, is such that actually you often get a drier field with these extended resections by doing it laparoscopically, as long as you have the right skills. But then the other downside of this, especially in a younger, sexually potent male, is you are very high risk, if not inevitably, going to damage their sexual potency, erection, ejaculation by taking those seminal vesicles because of the extended nature of your surgery. If the lesion's anterior but not invading, and you've given long course chemo-rad, but the margin's been threatened rather than actually compromised like it has, then you're thinking about the layers of denonvillous fascia, which again, we only, Bruce is now showing us these layers which we didn't really see before. And again, with 4K screens in our operating theatres, we're now seeing these layers with high fidelity, and we can then decide in a less invasive lesion whether we're going to take one or both leads of denonvillous, because obviously if you take both, you're more likely to sacrifice autonomic nerves and compromise bladder sexual function. So it's a complicated discussion with the patient as to what kind of operation and how you do it that you offer to them. And in a much younger patient, you might think, well, even though we take those organs anteriorly to the seminal vesicle, there's still a risk of a compromised margin based on what the original imaging showed. So you might even be still considering extended resection in this patient if they're very young and are absolutely keen to avoid a positive margin at all costs.
So first of all, we need to be, how confident do we feel there's still viable tumour behind? Because the watch and wait policy may be something that we're discussing. If you had a complete treatment response, then that surgeon with the patient may decide that we're just going to keep an eye on it and not do anything. So I think that this is still intermediate signal intensity, consistent with what the tumour looked like before we started. So I think that there's still viable tumour there, although it's much smaller. I still think that there's cancer there that needs addressing. And so, as I said, we did this at 8 weeks. So actually the decision with this patient is to, well, you've had a good response, why don't we see what happens if we leave it? And if we look now, this would be at the 12-week phase, this down now showing you. So, and now what we see is actually the normal submucosa, a bit of demetus. You can see the radiation changes with edema. But actually when we come down, now where the site of the tumour was, this is now very low signal intensity. And this is post-radiation fibrosis. You don't see that with chemotherapy, you see with radiotherapy. So make sure you know what treatment they've had. So this now, to me, looks like non-viable tumour. This is scarring. So I think that actually the submucosa looks pretty normal, and I can't see any tumour remaining. So now we're in a position that anterior margin is potentially clear, all right, and there's retraction of the scar. So now we're into a position where we can start to discuss a surgery again, because the treatment has been very good, and whether you watch and wait, or whether they would proceed with surgery, and some of that, if you decide how you decide that.
Yeah, I mean, well, let's take watch and wait to begin with, and it sounds like a sort of a rather gentle watch and wait. We'll just hang back and see what happens, and it's absolutely not, and especially in a patient to whom that decision is vital to their long-term survival and outcome, it's a very intensive surveillance program, and they have to buy into that and be compliant with coming for regular CTs, regular MRIs, regular endoluminal imaging, usually by colonoscopy. So it's a pretty heavy commitment for your system and for the patient. And the balance of probabilities is still in favour of them having recurrent disease if you watch and wait. So it really is for younger patients who are adamant, they don't want surgery, older patients who aren't so fit, and the majority will be pushing them in the direction of suggesting an operation is the best thing.
Would you suggest the patient has an EUA and biopsy?
So, I don't know. I mean, I think we often do that, but a negative positive biopsy, obviously if it's positive, more likely to drive in one direction or another. I'm worried about overly reassuring patients, though, because they suddenly latch onto this, and especially if you show them the scan, and then maybe you get a negative biopsy, which may not be representative, and they're going to say, thanks doc, I'm for watch and wait, I'll see you in a year. And you go, oh, hang on a minute, it's not about that. Firstly, you're going to have your bum poked every 3 months, and your CT and everything else. And secondly, there's still a high chance of getting recurrence. So, I don't know. What do you think about it?
I would just add regarding the biopsy in that setting is absolutely right. You're not really going to add anything, because if you have a big tumour and then it's regressed either entirely or almost entirely, the chances of the only bit of residual tumour being a mucosal aspect are pretty remote. So if there is residual tumour somewhere, it's more likely to be out with the bulk of the tumour out in the mesorectum than it is at the mucosal aspect. So a positive biopsy is helpful, but the chances of a random biopsy of a healed mucosal scar showing tumour are pretty slim.
And the only role really is not in this patient, but where you had an endoscopist who's taken off a cancer that's got a polyp cancer, questionable margin. You want to get back there as soon as possible, especially if they haven't tattooed it, because you want to see evidence of where the polyp was removed and take as many biopsies as you can. And of course, you've arranged your cross-sectional imaging, and hopefully that will have shown no EMBI or nodal involvement. So you're then having a discussion with a patient in a realistic way about watch and wait on a lesion that's been removed already, based on your biopsy results.
So this patient went to surgery,
Yeah.
had an operation afterwards.
So this is their abdominal perineal incision specimen. I hasten to add, this is not one of Mark's, because this is not really optimal specimen, but I think important to demonstrate in the context of the discussions yesterday and this whole meeting around assessing surgical specimens. So here we have the APER is pretty ragged with this anterior aspect here. These defects in there that really should be seen as normal. Overall, it's like we have the TME excuse, but we have an explanation here, because if somebody has an advanced tumour, for all that previous treatment and fibrosis, and especially the delays and all that time, then the chances of the surgeon being able to find nice optimal dissection planes are pretty remote, which is why I think is one reason why we don't want to use any judgmental terms in our assessment of TME or sphincter. So we want a report that looks like if there's any critique in there, because here we've got a perfectly valid explanation for the nature of the TME. So we just want to really comment on the planes, which in this case is muscularis propria. So when you see exposure all the way down to muscularis propria, as here poking out, then you want to really document that. Of course, you want to make the gaps and defects any bigger with than they are already, but you want to demonstrate and document that. So this is muscularis propria plane, and understanding then a section that's pretty ragged all the way around now. So we can't see any, there's an awful lot of change here macroscopically, but a bit like in the imaging, it's hard to say whether this is fibrosis or tumour until we see it down the microscope. And so basically what we would do in this context is we would have to put through the entire specimen in terms of any abnormality, because you can't sample in this case and then there's no tumour in it and say, oh, complete response. We need to put the whole thing in basically. It's a substantial piece of work. But we're really, this is all abnormal, but whether it's fibrosis or tumour, we won't know until we see it under the microscope. In this case, histologically, there was only a residual tumour in a couple of sections. It was actually in the submucosa only, so there was no tumour either in muscular propria or beyond. So it was almost a complete response. There was evidence of regression within nodes as well, so fibrosis changes there, but no cellular or viable tumour within nodes. So this was ultimately a YPT1N040, despite the suboptimal dissection phase. Before I finish, just want to compare with a different case. So this is the kind of TME we're looking for. So this obviously an anterior resection, not an abdominal perineal. So here we can see nice bulk of mesorectum, all intact, nice shiny mesorectal fascial cream, symmetrical, and what we would do in these cases, as we would demonstrate, we would paint this. You can use one or two colours depending on your preference, or maybe drawing to right and left, and you can see this in section with nice complete lines of tissue and this optimal mesorectal TME. So back to our case, that was a final pathology report. Minimum residual tumour, regression score 1, and regression evident in nodes also. And I found it interesting discussion of the MDM because then some raises will the species still get adjuvant chemotherapy on the back of that. So that's the pathology. So favourable, and that's obviously very good news because of the difficulty of the dissection.
And we touched upon that grading of TME specimen. Usually the only thing two surgeons can agree on is how bad the third surgeon is. And it's very, very important for your surgical group in your hospital to actually have good relationships with each other, because that's my poor quality TME, for example. You know, I don't want my colleague stabbing me in the back. I want them to say, gosh, that must have been a really tough operation. Radiotherapy, narrow male pelvis, maybe a few other confounding factors as well. So it's very important your surgeons are collegiate, identify with each other and have good relationships, and that's very hard to achieve, as I said, especially in medical surgeons.
So do you think that this patient with adjuvant chemotherapy on the back of the nose?
Just run the nodes by me again. So we're present on
Well,
so
essentially what we saw at the presentation, this would be into the bad category because it had discontinuous vascular involvement. So that would be a bad B. You know, that would be one that traditionally would get. Not just sensitising chemo that you give with radiotherapy, is so it's something I think is important for radiologists to appreciate, is that the chemotherapy which is given with radiotherapy is not systemic doses. It's enough to sensitise the tumour to the effects of the radiation, or the other way around. So somebody like that, I'm sure the discussion would be that they would then go on and have full fat chemotherapy afterwards.
So most of the evidence for adjuvant chemo was based originally around colonic tumours and some of the series incorporated rectal tumours. So it's important just to remember that you are extrapolating evidence to make your final decision. The second thing is with what is effectively a bad B, is it's about offering this to the patient, saying it's worthwhile you talking to the oncologist about the side effects, the risks and benefits, and the likely percentage increase in survival that you will have. Because you've got to remember, even with a Duke C tumour, an N1 to 2 tumour, that you're still treating about 90% of your patients for no particular advantage. They're either going to get recurrence anyway, or they're not going to get recurrence anyway, and they're just having chemotherapy to improve the life chances of the 10% that are going to experience an improvement. So these conversations, again, are nowadays more complicated, and there's different regimens available, and so on and so forth. We need an oncologist.
Yeah. But from a radiology point of view, and a pathology point of view, is identifying the prognostic factors is more than TNM. It's the vascular invasion, discontinuous spread. Those are the things, margin involvement. Those are the things that will determine
local recurrence and the appropriateness of other forms of treatment. And we need to be bringing those out consistently in our reports. Right, I think that was the last case.
Well, we've got a few things other than saying goodbye. I'd like to maybe get Piotr and do a group photograph. Is there anything else that you wanted to see? We're going to have a quick break and another half an hour, or what's the general feel? I've got some surgical videos, that sort of thing. Completely blank on that one. Should we have a... Seeing real surgery. Should we have a quick break and try and